You're listening to the Prehospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to be speaking with Brian Burns on prehospital retrieval cases in Sydney, Australia. So what I wanted to do is really talk to Brian around the range of prehospital cases seen in New South Wales, but also just explore the prevalence of trauma versus acute medical pathology, some of the types and patterns of injury encountered, the range and efficacy of interventions in prehospital care in Australia, and indeed the utility of each. So we're also going to examine the challenging cases that are unique to Australia and indeed some of the trends seen within the country. We're also going to examine some of the challenging cases that Brian has encountered and indeed the interplay Brian has experienced between skills required in the pre-hospital and indeed hospital environment. So Brian Burns is a trauma consultant at the Royal North Shore Hospital. He's a clinical professor at the University of Sydney and Macquarie University, and indeed an honorary senior lecturer at Queen Mary University, London. So most importantly, Brian is a staff specialist in pre-hospital and retrieval medicine in Sydney. Welcome, Brian, to the podcast.
Thanks, Owen. How are you doing?
Yeah, good, thanks. Really good, really good. Thanks. Thanks for joining us. I just wonder if we could just initially kick off, Brian, and just explore sort of how prehospital care is changing in the light of sort of an increased demand profile in New South Wales year on year.
Yeah, there are increasing demands on ambulance services in general around the world, and that's not just specific to Australia. The Australian ambulance services are very big. London Ambulance is very big. For example, I'll give you an idea. For New South Wales Ambulance, it's a single ambulance service for New South Wales, which is the size of essentially Western Europe, as far as I can make out. It's a huge surface area. It's got about 9 million people. The ambulance service gets about 1.3 million calls per annum, and that's going up all the time. In terms of the aeromedical services, certainly during COVID, the trauma burden actually decreased. So trauma and injury decreased during COVID globally, but as we're coming out of COVID now, the trauma statistics are actually increasing, particularly road traffic accidents in this country are increasing. And in fact, in New South Wales, in the last 12 months, they've gone up about 30% in terms of road traffic fatalities, and overall countrywide about 8%. So certainly there's higher risk behavior as we come out of COVID. There's definitely an increased mental health burden in major trauma or substance use issue and trauma. And then I think, in general, the population is getting older. So the silver trauma or the aged care trauma related statistics are increasing, and they're, low falls actually and rib fractures. So there's been a general increase in overall ambulance service work, but also as we come out of COVID, pre-hospital trauma has increased.
So we're just speaking offline, actually, Brian, around just the versatility you have to have. But really interesting, you made a point around there is no established Coast Guard or indeed search and rescue. So the actual mandate is on the teams, is on the medical teams to be truly versatile and flexible across sort of search and rescue and indeed trauma and medical. Could you maybe speak to the mix between sort of the trauma and medical pathology? What's indeed the split?
Yeah, so I'd maybe talk about what Sydney HEMS does, or the aeromedical operations. So we see about 3,500 cases per annum across 3 bases. So we have a base in Sydney, Wollongong and Orange. The other 2 are regional. And between the 3, we have 4 helicopters online 24/7. So they're 2 12-hour shifts, day and night, NVG capable. And we have road capability as well. And we also have fixed wing capacity to quite a large distance. And our teams are made up of a doctor that comes from an anesthetic or emergency medicine background who's specialized in pre-hospital and retrieval medicine, and a critical care paramedic. By fixed wing, it's usually the doctor with a flight nurse. And essentially, as you correctly said, the helicopters are asked to do a multi-role function. They're asked to respond to trauma, but they're also asked to respond to critical illness, no matter where that is in the state. And there's an aeromedical control center that lives in the center of Sydney that controls all the assets and anyone from around the state can ring a 1-800 number and gets put through. First of all, someone who triages, and then through to a doctor who kind of triages and decides when and where these patients should go, and then the operational crew on staff get tasked. Now, that operational crew for helicopter is a doctor, paramedic, an air crew person, and a pilot. So it's a single pilot operation. But yes, don't have Coast Guard helicopters, so we do perform a search and rescue function. So we've got massive searchlights on the side of the helicopter. We perform winch operations. We perform intra-hospital critical care, stabilization and retrieval, be it a medical problem, such as variceal bleed or postpartum hemorrhage or septic shock. And we provide complex retrievals such as ECMO retrievals, and we've had a long-established ECMO retrieval program. And then we do the usual common garden trauma care pre-hospital, including cases you really couldn't make up. I think Australia and some of these big countries, some of the things that go on and some of the injuries that we see are bonkers, really.
No, absolutely. You just alluded to there about the increase in mental health and the sequelae of mental health as well, because as you said, the overdose nature, or indeed drug driving, which is a real problem, I think globally actually, and ever increasing. And interestingly, like you said, a split between search and rescue and trauma and medical. So, if I'm not wrong, you have to be proficient in water rescue, and indeed incidents over water, which again is another facet of sort of specialist skills, really. Trying to winch over water, or indeed otherwise. There is an increase in prevalence of people moving about post-COVID, and you alluded to the fact there's been more RTCs or road traffic collisions and post-COVID. That brings a whole number of incidents and indeed pathology with it, from crush to penetrating to different injuries. Could you maybe speak to the sort of the prevailing pathology you're seeing post-COVID?
The penetrating trauma burden in Australia is low. It's a pretty safe country. So that about 5% of major trauma in New South Wales is penetrating. It's probably the same for the other states. That has not gone up. We obviously had a high profile incident recently in Bondi Junction where there were 6 people unfortunately killed and 12 injured. But otherwise, yes, penetrating trauma is not something that we see a lot. Having said that, most of the penetrating trauma in Sydney happens within a 10K radius of our aeromedical base, so we tend to see them all. In terms of road vehicle accidents, similar to other countries, the rural population is overrepresented in blunt trauma and in road traffic accidents. So that unfortunately seems to occur, and accidents involving multiple teenagers is an increasing phenomenon that we didn't see before. So we're seeing cases with 3-4 teenagers critically injured in one accident. And the common theme, I suppose, or the common drive for us is to provide immediate, time-critical, life-saving interventions and to keep them alive until we get them into the hospital for definitive care. So that there has been a lot of drive from outside in, and Steve Rashford in one of your podcasts was talking about that recently, and certainly that is the case here in Sydney and New South Wales as well. We're increasingly bringing unexpected survivors into the hospital, and the hospitals are having to gear up to receive those or to resuscitate those. And certainly, I'm a trauma consultant at Royal North Shore, and we have developed a system to try and cope with these patients with non-compressible hemorrhage, and we've developed a really cool, fascinating hybrid approach in theatre to these patients. So we call it Code Crimson. I know in Queensland they call it Red Blanket, and I think in the UK it's called Red Blanket. But we essentially activate the system, turn the system on from the field, and then go direct into the hybrid theatre in the place I work. I continue in there.
Yeah, indeed. And so when you say hybrid theatre, is that interventional radiology and or surgical intervention? How does that hybrid theatre work or look?
Yeah, so the way it works is it's a theater that has a C arm, so it has an image intensifier. Soon there'll be a CT scanner in that room as well, and it has an operating table. So, say for example, if you take a case of recent case actually of multi-trauma in a patient, and the real ones we're targeting are the ones who are exsanguinating and whose heads are okay, because we're hoping that they'll become meaningful survivors. And all your listeners will know that when you've got a shock patient, you've got the hateful eight signs, but also the oscillometric blood pressure cuff does not work. So in my practice, when you get random number generators like blood pressure 165 or 140, or the three question marks over three question marks, that's when I get really worried. And these patients, you often can pick the compartment with a fast scan, but even if you can't, that doesn't matter. I think for a lot of the surgeons and anesthetists, acceptance that the hybrid theatre or the operating theatre can be a place of resuscitation, not just operation. Then once you cross that Rubicon, so to speak, then you're in the area or the place that bleeding can be stopped. The bleeding cannot be stopped in the emergency department. So what we tend to do is we get them directly off the ambulance stretcher or the helicopter stretcher directly into the theatre, onto the table. One of the trauma consultants is team leading, so we get the retrieval teams to bring them directly in there, give a handover, and then we'll come up with a very rapid decision, senior decision making on which area do we think it's bleeding. So to give an example, if you've got a patient who's got a massive, splenic injury, the fast scan is positive, and we don't think they're going to survive the laparotomy, we have the vascular surgeons in there put a sheath in extremely quickly and put a balloon up and do a zone one, aortic occlusion, and then the surgeon will do a laparotomy, remove the spleen, remove the shattered spleen, pack the abdomen, then the balloon comes down. Or what we can do is say it's not that clear, we can get vascular to very quickly put a catheter up and start doing an angio run in theatre while all the other surgeons are in there and scrubbed. And they can come down through the body, go from the top, so from the top of the thorax down, and look for sites of major hemorrhage, and then decide to either do endovascular procedure to stop that, do a balloon occlusion to buy time, or to go to an open technique with the general surgeon. So the general surgeon and the vascular surgeon can be side by side, and it works well. There's a team leader that's hands off. That's usually the trauma consultant who's not scrubbed. And using aviation technology, we will say to those surgeons, right, your eyes down, you're doing the procedure, we're eyes up and looking around and helping coordinate the whole thing between the surgeons and the anesthetists. And it works well. It's all part of the process from the very first point of injury, from when the paramedics initially got there, held their area open, got oxygen into them, got vascular access before they came to shut down, gave maybe a little bit of fluid to keep them alive, and then the HEMS rise, and then does some further stuff, and then the hospital system gets turned on. It's all a continuum that needs to switch on to keep these patients going.
Yeah, absolutely. And to your point actually around it mandates CRM as well. So good crew resource management from inter-team sort of disciplinary work, which is fantastic to see. Brian, we spoke offline slightly about some of the challenges which are unique to Australia, and also the fact that we're in a more immature service or sort of less developed service because of history, you can be a bit more versatile. Could you maybe speak to some of the unique challenges that Australia and indeed New South Wales as a state poses, and that how you've maybe overcome those?
Yeah, I mean, I think if we're looking at trauma, let's look at trauma. So you could apply it to acute medical problems as well, like a ruptured AAA or a massive postpartum hemorrhage. But in some ways, the demands in this country are no different to any other, in that if someone has a severe problem, they need the right care as fast as possible in the right place. Now, sometimes they don't end up in the right place initially, but A, it needs to be identified, and B, there needs to be a rapid way of getting help. And certainly I think in the Australian systems, they've developed processes in each state to allow that to happen quickly. So as soon as these patients arrive in, sometimes the paramedics will pick them up in the regional rural setting. They will activate the aeromedical resources themselves through the control center by saying, "Oh, I've got a massive postpartum hemorrhage. We're bringing them to this hospital for further, access to blood products, etc." But they can actually control the control center, call the control center themselves, and get that process moving. And then for stuff like that, we have what's called a hospital primary system. So I could be staffing the helicopter and I get told by the aeromedical control consultant there is a P1 or hospital primary in XYZ hospital. You get going and we'll talk to you en route about what the case is. So there's a simultaneous action going on all the time. So that system is well described and well understood, that there is a method of getting help. Obviously, weather dependent. Weather can be an issue. And there's certainly weather matrix or risk matrix is used in New South Wales like in anywhere else. But then sometimes you can look at a fixed wing option. So those things do exist, and they can be turned on. The Aeromedical Control Centre is staffed 24/7. So there is that mantle of safety available to be able to provide support to the regional settings, be it trauma, bleeding, stroke, STEMI, whatever it is. And New South Wales Ambulance is pretty plugged into that whole system.
I just wondered, Brian, if we could just look at maybe indeed a challenging case that you have experienced recently, and just indeed, if you could just unpack the case, indeed, how you interacted on scene and some of the interventions that you initiated and how that went for you.
Well, over the last couple of months, I've actually been involved in a pre-hospital ECMO CPR trial. So I am not doing general aeromedical retrieval work at the moment. So we have this trial going called the pre-care trial, which is a pre-hospital ECMO CPR trial. But I can talk about one of the things that we do. One of my colleagues and the medical manager, Sydney Hems, Carol Habig, we do have clinical governance days, and clinical governance is a big deal to us, and we do it quite fastidiously because it feeds into how we operate. But every month, he'll talk about a learning from excellence case, and I asked him to send me some of the learning from excellence cases, and this is a recent case that our teams went to. And again, this is a kind of you couldn't make it up type case. This is probably about 200 kilometers west of Sydney, and it's a 49-year-old male single person motorbike accident. And he slid off the bike, and then he was run over by a ute pulling a horse float. So a utility vehicle pulling a horse float drove over this fellow, and he was dragged for 30 meters. The mist from the ambulance that was the mechanism. He was left-sided chest pain, and he had SATs of 85% on 10 liters, non-rebreather, clearly shocked with a heart rate of 140, GCS 15, and they had put in a single cannula and got some oxygen on. The helicopter was tasked and landed quite near the scene, but were taken to the scene by the ambulance. And this was a Sunday morning, and the traffic was backed up on this highway. So it's a regional rural highway. So on the HEMS team assessment, he was talking. SATs were 85 on 10 liters, so not good. Respirate 32, palpable rib fractures on the left, and he had a heart rate of 140 and no palpable radial pulse. He was pale, cool. Pelvis was non-tender. GCS 15, moving all four limbs. Ultrasound was attempted to have a look at his chest and his abdomen, but it was hampered by sunlight. So the progress was they obviously gave him some analgesia. They got a second line in, increased the oxygen. Finally, they got a blood pressure, which was 55 systolic. So this fellow is on a trajectory of death. Some more morphine to get him off the floor, off the ground. And they managed to get a repeat ultrasound, which showed there was no lung sliding on the left. They felt he was tensioning, put a needle in. SATs came up to 93, started blood via blood warmer, and they decided they're going to intubate him. And we often will do that. If someone's severely injured, we will sometimes temporize with a needle decompression, which is not a permanent solution. Get some blood into them, then anesthetize them carefully, and then do a thoracostomy, which is what occurred. Now, they activated what's called a retrieval transfusion protocol. We talked about a little bit earlier about the demands on the system have driven innovation, and certainly we have a lot of patients who would exsanguinate beyond the either 2 reds, 2 plasma, or the 3 reds that we carry. So they did activate a transfusion protocol quite early on. And in the control center back in Sydney, they have an app that tells them what blood products are generally kept on stock in which hospitals and where the helicopter is. And they often will use highway patrol police. They'll call the blood banks, they'll put an order through, and the police will bring products. So it's not unusual for blood products to start making their way towards the scene based on the paramedics' information before HEMS gets there, or while they're there with the patient who's trapped. So they did activate that, and they managed to get his pressure up to 94% of the time of intubation. We have published on the retrieval transfusion protocol, and I can send you that for the show notes. But during all of this, the traffic was building up, and there were some bystanders in the traffic starting to get quite angry. So now it's turning into almost like a simulation, because the punters are coming up and starting to get really angry with the police, and the police were starting to lose control of the situation. And in fact, one group of bystanders interrupted the intubation RSI to ask what was going on and how long this was going to be. Anyway, they managed to do that. They stayed on target, decompressed the left chest, and they got him on the vent. The RTP had arrived. They activated the code crimson that we talked about in the hospital, and they were met on the helipad with more blood. And this is another one of those 1%ers, because it takes 2 minutes for the helicopter to shut down. We don't do hot unloads of helicopters in New South Wales. But what we did do is the air crewman does exit the aircraft, goes to the door, gets more blood, and transfuses. We continue transfusion during the shutdown. We're actually talking about doing more pre-hospital art lines. So what that wasn't done in this case, but his end tidal CO2 uncontrolled ventilation was 44. So we're happy that he's still perfusing. So he's handed over to the trauma team, straight to the operating theatre, and his fast scan at that point was positive. And in theatre, he got another 7 units of reds, 13 FFP, 6 cryo, 2 platelets, massive left-sided flail chest, ribs 3 to 11, hemopneumothorax, pulmonary contusion. His diaphragm was ruptured. They actually found rib splinters in his abdomen. He's shattered spleen, grade 3 renal laceration, big retroperitoneal hematoma, lots of transverse process fractures. And he made a full recovery. He had rib fixation, splenectomy, and was sitting up and talking a couple of days later. Now, the interesting thing is that team got tasked on the way back. So that's one of our regional helicopters. And it's a fascinating job, I think, in performing under pressure, but also having to then reboot and set yourself up again. And we certainly train for this to be able to perform under that degree of pressure. And certainly our induction program that we run twice a year is fairly famous for stress inoculation and grading up the stress so that you expect something like the crowd to interrupt you to happen. You should expect it.
Yeah, indeed. So just something really interesting you said there, Brian, around this incremental gains, and absolutely to your earlier point around unexpected survivors. Blood starts to make its way to the scene. There is another transfusion on the helipad, albeit a cold offload once the rotors have stopped. But then going straight into this dual theatre, so you can sort of articulate where the bleeding is. But all these incremental steps are starting to really compound, and so that you are seeing these fringe cases which historically wouldn't survive now becoming
Correct.
survivors, which is fascinating in many regards.
No, I agree. And I'm lucky in my trauma role that I work in pre-hospital care, I work in emergency, I work in trauma. So I have seen the continuum all the way from the very beginning, all the way through to the theatre, to ICU, the amazing care they get in intensive care, and then the amazing care they get in the wards, and then the care they get to go to rehab. And it is phenomenal. And I think one of the most important things is, and what I do, and we all do, is to feed back to the paramedics on the scene who are initially there about how the patients are going. So I tend to do that, not just in the initial 24, 48 hours, but also further down the track, particularly when they're leaving the hospital. I'll let those paramedics know that this is how this patient went in the end.
Yeah, I think that's equally as important because it's good to be able to match patterns of injury and indeed injury load to because it's really difficult, I think, in the pre-hospital environment because these patients, I want to say undifferentiated. I think what I really mean is the load, the injury load doesn't present itself necessarily pre-hospital as far as the nuance of a CT scanner, or indeed interventional radiology, where you can really see the injuries and the sort of sequelae and the evolution of injuries. Whereas you get the big stuff pre-hospital. You hopefully might articulate the tension pneumothorax, but some of the more nuanced compression fractures or indeed retroperitoneal bleeds, it's super difficult. In fact, almost impossible in the pre-hospital environment to
Mm.
articulate and find those. So that feedback, I think, to paramedic crews is fantastic because then they can start to understand, like you said, why there was maybe a refractory blood pressure or systolic blood pressure which wasn't shifting or moving, because there was
Yeah.
a huge retroperitoneal bleed. So it's I think that's absolutely vital. Brian, just in the adage of time, I'm mindful of time for yourself. If we could just maybe just pivot and look at research priorities for a second, and
Yeah.
indeed, you did just mention there about an ECMO trial, which is
Mm.
fundamental, really, to really understand the adage of where ECMO should sit in hospital or indeed
Mm.
pre-hospital. Should it be a specialist centre skill? Should it be
Mm.
routinely delivered pre-hospital? Could you maybe speak to some of the research approaches and maybe indeed that
Yeah.
ECMO trial?
Yeah, I will. And before I do, because the point you made there at the end around the feedback is so important. And I think two things that I think are really important to help appreciate the injury. One is the mechanism of injury, which the paramedics have the luxury of being there and seeing the deformation to the vehicle or seeing the energy that occurred. That is so important. And the second thing is when they're using examination is to use their hands and what they see. So you see the mechanism, but use your hands and palpate the patient, particularly with chest. I think if anything, and this goes for hospital conditions as well, not exposing the patient and not palpating all the way around the chest, all the way around the back, you won't miss much. And what you'll find is where they are tender with that mechanism, there is an injury underneath. So, auscultation alone is not good enough. They really need to do that and then go with what you find. So, cognitive dissonance is a big one as well, where you got a monitor that shows blood pressure 150 over 120, but he feels very cool and clammy and the pulse isn't there. There's something going on there. So looking at those conflicting bits of information are very important. But we could talk about a whole podcast about that. We'll come back to that one. Yes, in terms of research, so we're very, very big believers in doing all kinds of research. Everyone will be aware of the hierarchy of research and, RCT or meta-analysis or systematic review meta-analysis at the top, but actually measuring what you do and doing quality assurance and proper governance is the most important thing. And Kareem Broey in London calls it sweeping the floor, and I 100% agree. You've got to see what you do. You've got to audit your RSIs. You've got to order your first pass success rate. You've got to audit what your use of blood is and how you use it and when you use it. What is the blood wastage? Audit the ultrasound. Look at the images. Audit basic care. Like I'm a big believer of doing the basics to a very high level, and nothing fancy. Nothing good will come out of anything fancy or any advanced intervention if the basics weren't done to a high level. If a patient has impact brain apnea or a severe head injury and the airway is not opened and oxygen is not provided, that patient, it does not matter if they get a craniotomy 2 hours later in a fancy hybrid suite, their brain is gone. So for the paramedics out there, it's a call to arms that your job is so important, no matter how junior you are, to do those basics to a very high level. And often that's not thought of as being extremely important. It's very important. So that's the first thing. In terms of research, we are focused a bit around blood product resuscitation. We're watching the SWIFT trial in the UK. We are running the Feisty-2 trial here in Australia at the moment. I'm one of the investigators where we're randomizing patients who have proven fibrinolysis to either getting cryoprecipitate or fibrinogen concentrate. I have watched the cryostat trial with interest. We are also running at Sydney Hems a pre-hospital version of the FIC2 trial. So we are using pre-hospital fibrinogen in the form of a trial. We're also trying to understand shock better when it's not due to bleeding. And one of my colleagues, Chris Partica, who recently published the SABRE trial, which is a serratus anterior plain block trial for rib fractures, is very interested in steering an international national group on describing these patients who have multi-trauma and they turn out not to be bleeding, but actually the shock is due to some other reason, like spinal cord or their head. So that is an area of interest. And then cardiac arrest has become a big area of interest, and cardiac resuscitation of mine and several others within our organization. And we've just finished the evidence cardiac arrest trial, the results of which will be coming out soon. So, for example, in this jurisdiction and in many jurisdictions, we are not sure whether you should stay on the scene and run the full resuscitation code as a paramedic, or whether you should, after a certain time period, apply mechanical CPR and then go to a hospital that can provide either cardiac catheterization under mechanical CPR or ECMO CPR. And that trial enrolled 200 patients, 100 in each arm. That'll be coming out soon. That's going to be very informative as to whether you should stay or you should go. Our feeling is that there are a cohort of patients in refractory cardiac arrest who would benefit from ECMO CPR. And a bit like trauma, where the interventions are being brought out as close to the point of injury as possible to save their life, it's no different in ECMO CPR. It's simple logistics. If the patients meet criteria and they can't get to the hospital fast enough, despite the best efforts of everyone, then can the system do it pre-hospital and do it safely and then get them into the hospital? So that's what we are looking at the moment. We are running a feasibility study at the moment in Sydney around can we identify the cases that are in refractory arrest who meet the criteria and then put them safely onto ECMO in the pre-hospital arena and then bring them to an ECMO centre. I do believe that the places that look after these places need to be high volume, or at least, medium to high volume centres, because yes, it's one thing cannulating patients and putting them in ECMO, but managing them and looking after them and managing all the complications and having buy-in is so important. And we've been engaging a lot with Dimitri Yiannopoulos in Minnesota around this, and it's the one thing that he keeps reiterating is you've got to have big buy-in from the center in all the things that can go wrong with these patients and fixing them. So I think if anyone's going to set up an eCPR program pre-hospital, you do need absolute buy-in from the center or centers that you're going to, and that they are expert in doing it.
Yeah, indeed, absolutely. And I think some of the pathways which have been established in the past, I think there needs to be a semblance of 24/7 service provision as well, because it's and I get the buy-in from having the resourcing and the staffing for maybe office hours, which is sometimes better than nothing. But these cases, to your earlier point around the it's quite often an antisocial service that prehospital care mandates. A lot of pathology presents itself in antisocial hours, so there needs to be this semblance of 24/7 provision. Something you said earlier, Brian, as we're starting to come into land, is the pivotal nature or mandates of clinical governance, and and again, something you just notion towards around always continual improvement. So just dissecting, attention to detail, data, being a data-driven service, and pushing the service forward through data. One of the fascinating things I've seen that's the evolutions in Sydney, or indeed in Australia, is just sharing of information, sharing of governance, even sharing of digital governance, Zoom governance, where different services dissecting cases, but
Yeah.
allowing each service to speak into other people's care. Could you maybe speak to, just because you do hold some of these really open forum governance days, and indeed sessions, and then maybe some more private ones.
Yeah.
Could you maybe speak to governance for listeners?
Yeah. So every fortnight, or once a month, we have a full day of clinical governance where we present um, morbidity and mortality. So on our on our electronic database where we enter our cases, we do tick cases that die in our care or cases that die within 24 hours. They all get reviewed. And then there's a curated morbidity mortality meeting, and that is open to anyone within New South Wales Health or invitees. And then we have a education day once a month. I think the key thing is that our education and how we develop and how we train feeds off governance and vice versa. The two of them work together to try and improve the process. So how we train for the next induction may be informed by some of the governance things that we find. And as you alluded to on the Sydney HEMS website, you'll see the AIR registry or AIR cases where one of our doctors, Dr. Claire Hayes Bradley, is one of our anaesthetists, literally curates all the airways and puts the interesting ones up there. So we do about 400 RSIs a year. I don't do 400 RSIs a year, but I learn from that shared experience, and so does everyone else, by what she puts up and the tips and learning points and tricks of the shared experience. So that is very powerful. The daily coughing cases is really a good one as well because it's informal. We link in with other helicopter bases around New South Wales, and we literally, people can volunteer cases and we discuss them, and then they're almost like a co-debrief in some ways and a peer review because we discuss those cases. And we've gone one step further with those. We'll then curate the learning points. So one of the senior physicians in the group and paramedics will curate them, and then we'll send out the learning points. And what's more, in the base, then there's a screen with some of the snippets or learning points every month that go up, and they're persistently up on the screen, rotating like subliminal advertising. So those little one percenters are important, and that governance is important. The other thing that's been developed is a significant event register, which is a QR code around the base where something significant has happened. You can report it and make sure that person, be it pilot or a crewman or a paramedic, is okay. And there are some events that are mandatory reporting, such as any death of a patient in our care, a critically ill or injured child, an aviation emergency, or an intercollegial conflict, at a hospital or with another colleague. And it's just all about open culture and trying to, sort things out. But yeah, I think our clinical governance and the way we review cases is a bottom-up driver. So we have those discussions. It's not like the management telling people what to do. We, through these governance days and case reviews, identify an issue that could be improved, and then we're empowered as individuals to improve it and then put it up for approval, and then it gets approved and off you go.
No, I think that's fantastic, and I really like the adage or the idea of just really showcasing these take-home points, or indeed these learning lessons, just so everyone gets to consume them, but also just reflect on them. Because again, like you said, to the 1%, it's for whole system buy-in, that everyone can kind of really understand the adage of what worked, maybe what didn't work, but the learning, fundamentally the learning from these cases,
Yeah.
I think is powerful. Brian, just as we come into land, just really the final question for the podcast for today. I could speak to you forever, to be honest, but it is more around just some take-home messages, really. If you could just make some take-home messages around the service provision of critical care within New South Wales. You've just spoken to some amazing one percenters across the scheme, but I think what comes through is this mindset of continual improvement, just from everything you've said, and not sitting back are constantly looking
No.
for ways to improve. Could I maybe get to speak some take-home messages?
Yeah, I mean, as one big overarching one is that there obviously is it's huge geography here. There's a healthcare deficit in the regional rural settings, which is the same as in every country, and the government has kind of identified that. So this organization I'm talking about and other organizations around Australia are government funded models. They're not charity based models. They're completely government funded, and that's how they operate. And so it's given proper um, kind of recognition that this is an essential part of the health system. So it's funded. That's one thing. Second thing is that the system is geared to try and get help to those people quickly. So there's a logistics aspect that's well organized and well thought out. And then in terms of what our mindset is to run towards the problem, I suppose, and try and sort it out, to expect it to be worse than it is, but also to come up with solutions for new things that we find are new issues. But also, as medicine and pre-hospital care is developing, try and prepare for the future and try and always look to improve. I think if you stay static over time, you basically decline. Um, Even if you're high functioning, you will decline. But if you improve over time, even incrementally, if you improve incrementally, you will improve over time. And I think that's pivotal to culture, isn't it?
Brian, listen, that's fantastic and a great place to finish. Listen, thank you for your time over the past 45 minutes. Really informative for me. And it's just been fantastic to get your reflections and thoughts. So thank you.
No, I really, it was a real pleasure to come on to the podcast, and hopefully see you again.
Definitely.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.